One. Good morning, everybody. Welcome back to another episode of Find Your Model Health for those looking to optimize their long-term health and weight goals and understand how their body works. I'm super excited to have just an incredible woman with a lot of experience on the podcast this morning. Today, as many of you know, we have Carol Petersen on the podcast. Carol Petersen is an accomplished compounding pharmacist with decades of experience helping patients improve their quality of life through bioidentical hormones and replacement therapy, specifically progesterone, which we're going to get into today on the conversation. She graduated from the University of Wisconsin School of Pharmacy and is a certified nutritional practitioner. She has just certifications coming out the wazoo. I think one thing that speaks most for you, Carol, is the experience that you had with the Women's International Pharmacy and all the different cases that you were able to look at with that. And you've also had experience with other pharmacists and the Pharmacists Association and whatnot. And the reason I wanted to have you on, as we spoke about several times, we have a mutual friend, Dr. Michael Platt, but also to really get your insight and the experience you have all the decades on hormones, really, specifically progesterone. But before we get into that, I thought we could start with maybe you sharing your experience with hormone therapy, specifically in perimenopause and menopause, and what got you here today.
Oh, well, it's a long story, but I can address that. And it's the key starting point, of course, is Women's International Pharmacy. And they started as a pharmacy along with a PMS clinic. And the idea with some investors were to create a whole satellite thing for treating women with PMS with progesterone. And this was based on Dr. Katarina Dalton's work in the UK. And she was phenomenal. She characterized premenstrual syndrome. She's the one who named it. She identified all these symptoms, emotional and physical, that still apply to PMS today. And she did some great work, published some great books. It's a whole body of knowledge. So she treated women with progesterone, very generous doses. And her preferred dosage form was vaginal suppositories.
Mhm.
You would start out with 400, 600 milligrams of progesterone per suppository and maybe go up from there to treat these severe symptoms. So back to the US, her work was catching on. And were two doctors, Hargrove and Maxon, and they worked with a pharmacist with this too. They wanted to see if progesterone could be orally absorbed enough so it could be a suitable dosage form as an alternative to the suppositories. Normally, it was thought it couldn't be absorbed, but a couple things happened. One was the micronization of the powder, progesterone powder, making the particle sizes smaller and smaller, which made them easier to absorb. And they also determined if you put it in an oil or a fat while you took this, or you could take it with a fatty meal, it would be absorbed better. And they found that they could get some good serum levels with using progesterone in the capsules. In fact, you could get luteal levels of progesterone recorded. This turned out to be phenomenal, treating women with PMS, with severe symptoms, women who are homicidal, suicidal, headaches, severe mood disturbances, could finally find relief, and it was just absolutely wonderful. The problem was trying to get enough progesterone into these women, and our starting dose would be 100 milligrams of progesterone in the capsules 4 times a day, and up from there. At the time I counted, when one woman, she was at the highest I had seen, she was using like 2,500 milligrams of progesterone in various dosage forms. We would be compounding vaginal suppositories, rectal solutions, lozenges, creams, and gels, everything to try to get enough progesterone to overcome these symptoms.
Mhm.
I learned a couple interesting things from this experience. One is, we called it breakthrough. When somebody was using enough progesterone, was pretty comfortable, and like a symptom of anxiety would start creeping back. We called it breakthrough then, and the doctors knew to prescribe a quick acting lozenge or something to bring that back up quickly. So patients could manage their symptoms by adjusting the amount of progesterone they had. There's a phenomenon, and one Facebook page calls it the estrogen kickback.
Mhm.
When you have too little progesterone, particularly when you're starting and you use the doses like John Lee recommended. Dr. John Lee pioneered with a book on progesterone. He did a study with trying to show it was useful for osteoporosis. He recommended 20 milligrams as the maximum you would need, because that's all your ovaries would make for you. However, progesterone's being made all over the body, which at the time he didn't know.
Mhm.
And these small doses, which you can find over the counter someplace in health food stores and whatnot, they can actually make some women quite crazy, to the point of sending them to the hospital, because that little amount of progesterone can, as I said, estrogen kickback, suddenly increase all the estrogen type symptoms, which could be anxiety, breast tenderness, headache, fluid retention, just maximize that. And not enough progesterone to go around. Progesterone's quite remarkable in all the things it does in the body, and these little doses would just provoke something negative. I've seen in the medical um, literature, what do they call it? I want to say reversal, but it's when a certain dose of something has a negative effect and another dose has a positive effect. You want to make
Mhm.
sure you're up where you're going to get the positive effect.
Yeah.
This is counterintuitive to many physicians, practitioners, people. They try a little bit of progesterone, they feel terrible. So, oh, I've got to take less. Well, that's even worse. Or I can't handle it at all. When in reality, they were severely underdosed and all they had to do was bump it up. So I learned that from the severe PMSers, that you could bump things up, get relief very, very quickly, and no need to be staying at these doses which don't serve you, and I think can actually be dangerous. So I'm really appalled. So many practitioners, they'll give somebody 50 milligrams of progesterone and see you in 3 months, and women are suffering for all this time when they could have bumped up their progesterone dose and been comfortable the same day. That's
Mhm.
it's appalling to me that this is ignored. There's another thing I learned from these PMS days. So conventionally, we're told that bleeding starts when progesterone drops. If you look at the menstrual cycle charts, estrogen drops too.
Mhm.
But they say it's a drop of progesterone that brings on bleeding. However, with PMS sufferers, they may be still having symptoms 1, 2, 3 days into bleeding. And so they never stopped their progesterone, and they bled right on time anyway.
Yeah.
So there is some other function going on here. So out in the general consensus is that you have to stop progesterone to bring on bleeding, which doesn't work some of the time.
Yeah.
You stop your progesterone and you don't have enough progesterone at that point to make that endometrium secretory. This is another thing. Progesterone has a dual nature in the luteal phase. First part from ovulation to mid-luteal, progesterone is working along with estrogen to make sure there's a nice, rich endometrium for the egg to implant. From mid-cycle to the end, first day of bleeding, if you have it implanted, then progesterone becomes a secretory hormone. It prepares your body to lose that built up tissue. And I firmly believe the problem sometimes is that not enough progesterone, like the area under the curve,
Mhm.
can be a problem with having successful bleedings. And as you go into perimenopause, we not only have issues with skipped ovulations and no progesterone being produced
Mhm.
from the ovaries, but we also have the situation where there may be an ovulation and maybe progesterone is not produced in amounts large enough to really do that efficiently. So sometimes we get women building up their endometrium because they haven't had a good bleed, a good amount of progesterone to make that happen. And then they get put on the pathway like we're going to have to do ablations or DNCs, or we're going to send you for a hysterectomy. The other thing that happens with bleeding is progesterone during the first part of the cycle. And people don't appreciate that this comes from the adrenals,
Mhm.
and it's a huge amount of progesterone, even though on the charts it looks little. They've measured the estrogen in picograms and the progesterone in nanograms, sometimes fail to tell you that it's two different units of measurement. So where progesterone is appearing on that menstrual chart way down at the bottom, that line should be 1,000 times higher than it is. So
Yeah.
it's vastly more abundant than estrogen, but everybody thinks estrogen is the thing during the follicular part of
Yeah.
the cycle. So another thing that happens is the adrenal progesterone can get compromised when you're under a lot of stress. Eventually, it helps you make your other adrenal hormones, and it gets depleted. And when it's depleted, estrogen is free to build up a bigger and bigger layer. So then you have this situation in perimenopause where women experience these huge bleeds, and it's so easy to fix. It's simply putting progesterone in that first part of the cycle. What are your solutions if you go to your conventional doctor? They're going to put a Mirena coil in you,
Mhm.
synthetic progesterone. Sometimes it helps with the bleeding, sometimes it doesn't, but you're mucking up your endocrine system with a foreign chemical.
Mhm.
And if that doesn't work, you get the other things, ablations, DNCs, or you're fast tracked to a hysterectomy because, of course, you're not going to have children anymore and you don't really need this organ.
Oh, I was offered a hysterectomy when I was 32, so 4 years ago, 5 years ago, and I was, my face dropped. I was like, are you serious? Are you crazy? And they're like, well, are you gonna have any more kids? And I was like, well, no. Well, then you don't need. I'm like, I would like to keep all my body parts, thank you very much. But the fact that they offered it so freely, I was very shocked, especially at my age. And I've many clients being offered it now, and it's disgraceful.
It really is disgraceful. I found a study, and it was, I think, the University of California, San Diego, and it involved endometrial cancer. So you might say, well, you might want to have a hysterectomy if you had cancer. However, what they were doing was creating a test for how advanced your endometrial cancer was. And the test was the number of progesterone receptors. They found that the number went down as the disease was getting worse. So progesterone not only wasn't available, it wasn't able to have any available receptors. In the pre-discussion to this article, said that it had a reference and said, well, it used to be endometrial cancer was treated successfully at least 50% of the time with progesterone. So you don't have to go on to have surgery, and you don't have to suffer from cancer eating away at your life for years. So it's just extraordinary to me.
But where, with that said, and what you mentioned earlier with the lozenges back in the day, doctors knew that if there was a breakthrough, so you're on progesterone and maybe all of a sudden you get a migraine, then you could take a lozenge, just give you that quick boost of progesterone. And the article you just referenced there, when and where was all this information lost in our current conventional medicine?
We never had it for for a lot of things. Shortly after, in the 1940s, when Russell Marker created the synthesis, and I'll use that, of progesterone
Mm,
from a plant steroid, and it was yam, because it was abundant. Can be any number of plants have the same kind of steroid you could use. So he was able to alter that basic steroid like cholesterol to make the molecule exactly like progesterone.
mm,
And hence we were able to start using it. Prior to that, the only way you could get progesterone was they would extract it from human placenta because that was so rich in progesterone. But very, very expensive processes, you might think, it made progesterone too expensive to
mm,
actually use. So shortly after, it wasn't very, very long after, they created the first synthetic progestin, which ended up in birth control pills.
mm.
So we never fully explored progesterone in our conventional medical systems. Far more birth control pills are prescribed
Yeah.
than was progesterone ever. So our medical systems are not trained very well on the use of progesterone, and some of its remarkable qualities are just lost to them. They have zero knowledge.
It's such a disservice and it makes me angry, but I'm sure you're at the stage where you're past the anger. You've almost had so much experience, you've accepted it. And I heard you mention in another conversation you had that some of these teaching hospitals are going to just stop teaching about this hormone therapy and perimenopause because I think you said there's no point anymore. We can't do anything about it, so let's just not teach it at all. Which, hold on, I thought like I already thought we weren't teaching it. Now we're definitely not teaching it.
Definitely not teaching it, at least in New York City. This was in the New York Times. This woman, Susan Diadamo, or Diadamus,
Mm,
I believe that's her name. She was like a Pulitzer Prize winning writer, and she had become perimenopause and was losing her sharpness of her brain, searching for words and things like that, really a handicap for your profession.
mm,
So she decided to embark on what she could be doing to help herself. And she went, of course, to the big teaching hospitals there, Mount Sinai, um, NYU. There's several, there's a lot. And um, they gave her very little help, and she ended up on birth control pills to help her with her symptoms. And it's ironic because she never did explore bioidentical hormones. And I personally know quite a few practitioners there in the heart of New York City, treating patients very successfully with hormones, topping up your own hormones instead of synthetics like she was doing. I actually did two radio programs because I do a radio show out of New York City, Take Charge of Your Health. We did 2 weeks on kind of countering what she was saying, that it was hopeless. And she's the one who said they weren't even teaching about it. Now there's right now there's a woman, Mary Claire Haver, who in the US is creating this kind of empire. And she's written a book called The New Menopause.
Mm.
And she's got a cadre of physicians set up to be telemed practitioners. She's got a line of supplements she'll recommend. It's quite remarkable. She's got this whole thing. Her book is atrocious. Um, her book is right along the lines of the Organized Menopause Society, Endocrine Society, American College of Obstetrics and Gynecology, who dictate to their members what they ought to be doing. And they write papers, position papers, and things like that. And let me just pick one thing out, the bleeding, the excessive bleeding, which I told you was so easy to fix with progesterone.
Mm.
So, but that's not what they're teaching from these organizations. It's of course to go to the marina, and if that fails, take it out. That's what she has in her book. And so I here we are capitalizing, this woman's capitalizing on this lack of information to the public and to practitioners, that practitioners don't have it either. But these organizations are well funded by big pharma, and they create these what do you call, I would say, flowchart medicine. If this, do that, they create all these things and really say some stupid things. These organizations are responsible for, if you've had a hysterectomy, you no longer need progesterone because you don't have a uterus to
Oh.
protect.
Mm.
And what craziness. They also are responsible for a statement like that, like this. We have, for lack of further information, we have to we have to accept that all estrogens behave the same way. Once in a while, I see
All 30 of them, or just
all
one?
all the ones on the market, the Premarin and estradiol, which is bioidentical, and then the um, ethinyl estradiol, like in the birth control pill, and there's a few more. So we have synthetic um, other versions that are supposedly satisfy the estrogen receptor but are less stimulant. So there's all kinds of drugs in this category. So we're going to treat them all the same. And it makes me wonder, I say, did your doctor fail their physiology and biochemistry course that you accept this this nonsense? It's actually incredible. Yet doctors are parroting these things to their patients all of the time, and it's pretty shocking to me. And I don't know how you can continue to leave your patients miserable and not wonder why what you're doing and your organizations have told you to do it. Why are your clients still miserable? So I worked for Women's International Pharmacy for 27 years, and I got laid off at COVID. And so I was pretty upset. But one of the things I did right then, because I was missing this interaction with people, because we consulted, hundreds and hundreds of women and men too every day. And so I was really missing that. So I went to Facebook because what I was really looking for, I was looking for the failures. And this is what practitioners don't get to hear. When they failed, their patients go someplace else. They keep looking. And so the doctor's not learned anything. He's not learned whether what he did was good or bad. I mean, if it's good, they keep coming back. But if it's bad, she doesn't know it's bad because they don't get the feedback that it's not working. Or if they do get that feedback, and I'm sure many will give them some feedback at some point, they don't take it in and say, what's the problem here? How can we fix this? And part of that is due to the training now that the doctors are no longer taught to use their brains or their intuition. I heard a nice somebody said something nice today. I listened to a podcast earlier. It said medicine is not a science.
Mhm.
Um, it's an art, and
Yeah.
it really is. And and this is what's being left behind with conventional medicine, where uh, the science really isn't there. It's contrived,
Yeah.
but they behave like it is. And so we as healthcare consumers have nowhere to turn except to Facebook or something, or doing these podcasts. We're trying to help each other
Mhm.
get to the answers.
And then there's a lot of these doctors then and practitioners and even consumers that will go and read that book that you just mentioned and go to that association and take those words as gospel. And then those people then become harder to reach for people like you and me and to break that conditioning. And it really is, again, a disservice. It's a sin. And I suppose me and you offline could converse on why they're doing this. Why is there such a push on estrogen lately and all these synthetics? But one thing, if you don't mind hopping back to, because it very much relates to my clientele, and I'm sure yours and followers, is the stress aspect of this. So I can count on two hands many of my clients who will go through a very stressful event. I mean, who doesn't have stress nowadays? All of us, nobody's exempt, but they'll have very stressful days, or some of them are doing night shifts, so nights. And then they'll experience chronic migraines. Like these migraines are debilitating to some of my clients all day, every day. I don't know how they even function at all. And then the bleeding, and then multiple bleeds throughout the month. I just had a client offered either an IUD or a hysterectomy. So all of this seems to come back to stress, seems to be the trigger. And what you mentioned was in the follicular phase, where the adrenals would support our progesterone production. If we all have this abundance of stress, we're getting that cortisol, pregnenolone, steal, taking our progesterone. So now we don't have progesterone offsetting that stress, and then we don't have progesterone to signal everything's safe, we can ovulate. Now we're not ovulating, now we're not making progesterone in the luteal phase. Now there's no progesterone anywhere. And then people are looking for help and they're not getting help and they're resorting to practitioners like ourselves for help.
Yep, that's right. I know you're going to be talking with Dr. Platt, and his book, Adrenaline Dominance, is really an important book.
Yeah.
Now, when I was talking about um, estrogen kickback, estrogen dominance, uh, it's only part of the story. And Dr. Platt had the other piece
Yeah.
because uh, I began to think some of this kickback stuff can be heart palpitations, irregular heartbeat, high anxiety.
Mm.
These are high adrenaline symptoms. Like adrenaline is way out of sight. And now there's another big issue with this adrenaline out of control. Progesterone balances it. Um, it can balance so you don't get quite as much production. It can balance, I think there's some blockage at the receptor site. But when this adrenaline is in high force, it takes tons of progesterone to get anywhere near calm. And so I have to look at what can we do to help manage all that adrenaline. And now we have the situation about 40% of the population does not methylate well. That's a detoxification
Mhm.
for estrogens, for adrenaline, and even for histamine, which is another problem that progesterone can help. It's a strong antihistamine. It stops histamine from being released from the mast cells. So now we have to look at methylation. And so we have poor methylators. And we can get some clues from a serum test for homocysteine if that's high. You're not methylating. You can have genetic studies. If you do a urine test and 4-hydroxyestrone is high, and they warn you that this is bad, this is too stimulant, estrogen, that needs to be methylated too. So you know if it's rising, the methylation isn't happening. So we have some ways to test to see how well we methylate and what do we do for that. So you can take um, things that have methyl groups that will help you have a bigger pool of methyl groups. And they are the methylated B vitamins. You can take betaine hydrochloride, which is really nice before meals. It also supplies some fat. Betaine is trimethyl glycine.
Yeah.
Phosphatidylcholine
Mhm.
is a precursor to betaine, so you can get it there. There's a supplement called SAMe. All of these provide you some methyl groups. Then I really recently discovered another possible help with this, and it's creatine.
Yeah.
So
Although before we go on, if you don't mind, because maybe you can answer this, and I guess it's the adrenaline dominance as well. Um, Not just women, a lot of people will take creatine regardless of the dose, if they're doing a loading phase or low dose, and they will just feel out of sorts and they will get the jitters and they will stop. They don't want to feel like that. And I would guess that the creatine is influencing the adrenaline there.
well, creatine is a methyl sink, is the word they use,
Mhm.
meaning your body needs to maintain its supply of creatine, and in doing so, it needs methyl groups to create it. And then when you're using up all your methyl groups to make creatine, you're not using it for your detoxification purposes. That would be the thinking around that. And you actually can see when somebody is low in regular blood tests, they have creatinine, which is a metabolite, and they follow that for liver, excuse me, kidney function. If you have low creatinine, you have low creatine, and you can supplement to bring that up, and you should. Or if you're not a meat eater, you can eat creatine, and its muscle, um, animal fats and proteins will help you make the creatine, help you have some abundance of creatine. If you're a vegetarian, you have no way of building that up except your own body sucking up your methyl groups.
Yeah.
So it can be a problem.
Hmm.
So and I hope there's still more that we haven't worked out yet, because I still see some clients and it's really out of control. Like so much adrenaline, they're literally shaking and the anxiety is unbearable. How can we go on like that? So that's my possibility. Adjust what you eat, keep your insulin glucose under control, because what Dr. Platt teaches us, blood glucose goes down, up goes the adrenaline. And then if unfortunately you can't detoxify it very quickly, you're in a real big problem. Now, having said that, let's say you want to use extra progesterone to help you, and all you have is a cream. Well, what happens when you're in this high adrenaline state? It's fight and flight. Your circulation to your skin is impaired. So how can you get the progesterone absorbed when the circulation is slowed down? So the very thing you need to help you isn't going to get in very well. So I know people with creams, many of them have started freezing their cream doses and doing it intravaginally, which would help. um, you get a little bit better absorption there and have more potential. And that's probably why it works better when you're in that state. So it's a real problem, I believe,
Yeah.
when this high anxiety occurs and you want to use progesterone, it's really hard to absorb from a cream.
So while we're here, what about dosing? I have clients who are extremely high adrenaline. as much as nobody likes to hear that. And there's also a big misunderstanding around adrenaline because we constantly get plowed home that it's all about cortisol, 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 and people forget about adrenaline completely. When a lot of people, I think of adrenaline, they think of adrenaline junkies, someone bungee jumping or jumping out of a plane. They don't, because we're barraged with the concept of it's all cortisol, and I think me and you agree. Well, it's not. It's adrenaline, and then we've got the cortisol that follows. But dosing, especially with the cream, and this, I have loads of questions here, so let me pick one to start. So dosing with the cream, my average dose, which I know is low, and we can discuss why it's so low shortly. And you're based in Canada too, for everyone. So Carol can relate to the struggles in Canada. So my clients are dosing anywhere from 100 milligrams to 400 milligrams a day with the cream, and primarily Plat Wellness cream. And for a lot of them, it's still not enough. So sometimes I will, depending on the person, I'll also introduce something like Vitex to just help with the progesterone, even in the second half of the cycle. Some people will use maybe an extra tincture, but this is where the challenge is. How are we dosing people?
Right, right, in this high anxiety state. Now, I heard a lecture with Dr. William Clearfield in the States a while back, and he said he starts anxious women on 400 milligrams of pregnenolone a day.
Mhm.
So I nearly fell off my chair. And so I asked him later personally about it, and all the whole dose is at bedtime. And so I go, well, what's wrong with what's wrong with that? I do recommend pregnenolone, albeit at lower doses. And I do recommend lots of progesterone. Well, pregnenolone certainly can help that part of the steroid cascade from cholesterol goes to pregnenolone, goes to progesterone, goes to cortisol. That's a whole area that's being undersupplied. So why not? So I'm doing about 400 milligrams of pregnenolone with myself. I didn't have any symptoms before, so I don't have any real change.
Yeah.
But I like pregnenolone, especially if somebody is having issues with candida. Using progesterone can make that candida worse. You got to get in top of that candida. Pregnenolone isn't quite so big a problem with candida. So maybe you can start loading up that first, or maybe some progesterone, some pregnenolone. And what I've been doing even more often is hydrocortisone, because that too is low.
Yeah.
And it needs to be balancing the adrenaline too. So the hydrocortisone, you can get over the counter 1% hydrocortisone cream. So I looked far and wide till I found one that doesn't have a bunch of junk in the cream. If you go to the regular pharmacy, you're going to find things that have quite a lot of chemicals in it that you rather not put on your body regularly. But if you find a nice cream, 1%, quarter teaspoon would give you about 10 milligrams of hydrocortisone. There was a wonderful physician who spent 30 years of his career studying just hydrocortisone. His book is Safe Use of Cortisol. It's William Jeffries.
Yeah.
And he recommends this small dose of cortisol, which is the same as hydrocortisone, every 6 hours. And I've been finding that even women with already using progesterone, this can give them a foot up. They like it. And I like to have that available. What does low cortisol feel like? If you've ever had the flu where you're so fatigued you can get out of bed and your muscles and joints all ached, that's what low cortisol does. And Dr. William Jeffries did do a study where he found that what's happening is our pituitary ACTH, which is supposed to be stimulating the adrenals to make cortisol, that's blocked.
Mhm.
when you have the flu. Whatever is going on, that's blocked. So you really have a big deficiency. So you could sit in a bathtub with cortisol and it's never going to act like adrenaline and make you nervous. It's going to be calming. It's a calming hormone. And yet we give cortisol all of the traits of adrenaline and say we've got to get our cortisol down. And I said, no, my goodness, it's protecting you as much as it can. Yes, we've got to get back to reducing the stressors somehow. But in the meantime, God just bless you that you're able to make this extra cortisol to have you deal with that stress. And there are women who are afraid to take progesterone because they think your cortisol will go up. And I said, well, it's good if it goes up because that's where it's going. Your body's directing it for you to make extra cortisol because you absolutely need it. When the need goes away, down you'll come.
Mhm.
It's very interesting. So I like those two other hormones on each side of progesterone to also maybe help with those so you don't need to do everything with progesterone.
Mhm.
So that's what I've been doing. And maybe for calming, you might want to add GABA
I use
along.
GABA a lot. Now,
Okay.
let me ask you something. This just popped into my head. It wasn't on
And
the
they,
agenda.
yeah, it can work together with progesterone and help enhance its effects. So,
I've seen this in a handful of people over the years. It's very few and far between where someone who has a lot of adrenaline will take GABA and it'll make them worse. And I have searched PubMed, I have searched everywhere for the answers. And I can't find out the reason. My only guess is that their adrenaline is so high and their progesterone is so low that then taking GABA causes some sort of exertion of stimulation instead of calming them. It doesn't happen often, but I have had that experience.
yeah, and let me just say something. Progesterone works at the GABA receptor. It's particularly good when it is doing it. It produces calmness and it helps create deeper sleep, so you're better restored. But this is a different pathway than what it's doing with adrenaline. And I think maybe the problem you've run into with that is the pathway where it's trying to calm adrenaline is is the major thing, and just giving GABA is either countering it or not filling the needs to how you can handle adrenaline with progesterone. So I think it's two, you get anxiety in each case if progesterone is not working at the GABA receptors adequately, or if you have high adrenaline, you've got anxiety. But these are two different kind of problems that progesterone can be helpful with, but perhaps you should be placing the attention on the adrenaline. Now, this is a real interesting thing too, as a pharmacist. High blood pressure. Three separate classes of drugs are especially designed to block adrenaline. So, hello.
Yeah, we know this is a problem.
Hello. Yeah, we don't know why you have high blood pressure, but we're going to give you a beta blocker. What's the beta blocker beta blocking? It's beta blocking adrenaline. That's that's how that particular thing works. And in fact, I had a client the other day, and I was quite surprised because her doctor actually gave her propranolol, which is a beta blocker for high anxiety moments, and it works.
Yeah.
Well, I would expect it to work. So as much as I hate drugs, maybe this is an emergency use thing that should be done. Maybe when you go to the hospital with your heart pounding out of your chest, you shouldn't be given a benzo. Here we go back to the GABA stuff.
Yeah.
You should be given that beta blocker to be blocking that excess adrenaline. So I think there's a fault there. And if you go to the hospital in this emergency situation, they won't find what's wrong with you because they're going to put all their attention on your cardiac activity, and they're going to put you through a whole series of tests, and they'll come back and after numerous tests, and they'll tell you, oh, everything's fine with your heart. Well,
Well, yeah.
that wasn't the
I
issue. It was the hormones. And we don't have good tests for adrenaline. We do have some organic acid tests. They do have some of the metabolites of adrenaline. I've seen a few of these, and I've also seen where it really wasn't registering high adrenaline, yet the symptoms were frequent with these people. So I'm not sure that it's a good measure. And really, your doctor wouldn't even think to try to evaluate you for that high adrenaline. Some good adrenaline markers might be, is that high blood pressure could be high adrenaline. How about there's a thing called the Coca pulse test.
yeah.
And so you measure your pulse before you eat, and then you eat. If your pulse rate goes up by 10 beats per minute, you have a sensitivity to something you just ate. And you can start isolating this and avoiding these foods, whatever is setting you off, at least for 3 months. But what's happened? Your pulse rate rises because of adrenaline, and that particular food caused an insulin glucose swing, adrenaline being produced. And there you have it. It's something you can use to guide you. That increased pulse rate all of a sudden is a big signal of adrenaline release.
I think one of the most clear symptoms that you have high adrenaline in anyone is if you have insomnia or you have issues sleeping, turning your brain off at night. You've got adrenaline. That is anxiety being caused by adrenaline. And then the next one I would look at is diarrhea because I've experienced that myself when I have high adrenaline. Everything goes through me. But for sure, it's the sleep, which who doesn't have sleep issues nowadays? Back to everyone has stress.
Okay, so way back in the 1930s, there were some older endocrinologists, and they call this phenomenon when you wake up in the middle of the night, um, and you're fully alert and can't go back to sleep. They called it liver insomnia. And their solution was the one doctor writing about it said to put an apple at your bedside and eat the apple, and you could go back to sleep. What was happening here? So the liver hasn't stored enough glycogen to supply blood glucose for the whole night. So you run out of glucose from the glycogen, and you drop into a low glucose situation, which triggers the release of adrenaline, and adrenaline makes you wide awake. So for some, eating, or you can also use progesterone. Progesterone helps correct a low blood glucose in the middle of the night. You should be able to go back to sleep and get a full night's sleep. But underlying that, I would check on what's the liver doing? Why can't it store enough glycogen? What's your diet like? Does it not promote storing enough glycogen? And there's another problem with the liver I've discovered is there are lots of people with very low cholesterol levels. And I can't say the Canadian numbers, but cholesterol levels like 150 total cholesterol and lower. Had one young girl, 32 years old, with seizures. Hers was 86. I don't think that's compatible with life. You
Mhm.
need you need cholesterol to make your own hormones, your vitamin D and your bile. And how can this be going on? And I'm having a lot of trouble. Is one of my things I'm trying to do a deeper dive into is how do we get the liver to make more? Because your liver is responsible for making 90% of your cholesterol. So in the meantime, I'm making sure that they eat more cholesterol, but eating cholesterol does not necessarily cause your
Influence.
cholesterol to go up.
Yeah.
It's really, really difficult to get this up.
Yeah.
So I don't know the answer there. I'm still looking.
Well, there's a thyroid factor, and I know we could have a total other conversation around the thyroid. I'm just watching the time, and I have so many questions for you. But one thing I suppose I want to finish up with today on is in back to the dosing and availability of progesterone to women, especially in Canada, not solely in Canada, but especially in Canada, is the resistance by doctors to prescribe progesterone, let alone their ignorance around different types of progesterone. But women then are having to go online to all these different places. So Planet Wellness, there's a few other stores to source their own progesterone. So then it comes to cost. You're having to pay out of pocket. Then you've got the shipping costs as well. And this I see is one thing that holds a lot of my clients and followers back is it can get quite expensive. And then if you're encouraging people to dose higher and higher and higher, now you're going through your cream or your tinctures or whatever faster. And this really is a challenge. So what do you say to this?
I know I haven't solved it outside of um you almost have to go to pharmacies in India and get your own in Europe.
Mexico,
uh,
yeah.
uh, some women, they may take a trip to Greece and it's over the counter and they just load up, take it back home to England. uh,
Suitcase of progesterone.
right, it's just it's incredible. And even in the US, I would assume probably similar in Canada, they doctors are reluctant to prescribe more than 200 milligrams, um, because I think of these white papers or whatever these programs are putting out. I'd like to refer everybody to Dr. Jerry Lynn Pryor's website. It's Semcor, CEMCOR.ca. She has done absolutely remarkable number of studies with progesterone. Her interest particularly was osteoporosis in young athletic women. They just burned through their hormones, particularly progesterone, and became having problems with osteoporosis in their 30s, which is unheard of. And she's published that progesterone is a bone building hormone and absolutely essential. There's a
But I thought estrogen was our bone building hormone.
no, no, no. You know, it used to be, they said, it slowed down the rate of bone loss. And to my astonishment,
No.
lately I'm seeing in conventional medicine, they say, oh, estrogen's the bone builder. No. And I'll tell you, if you take estrogen alone, and here are all those women post hysterectomy, estrogen alone, there is a pathway where you actually deplete your bones more. High estrogen and coupled with low thyroid, and sometimes it's caused by these high estrogen levels, it causes your prolactin level to go up. And then the high prolactin will cause parathyroid hormone to go up. And when parathyroid hormone goes up, it tries to moderate its activity by pulling calcium from your bones.
Mhm.
So the amount of damage doctors have done with that particular very wrong state of mind is incredible.
Yeah, I know. It's shocking. And then you throw in women who've been on birth control from a very young age, and now they hit their 40s, 50s, they've rheumatoid, they've osteo, and they don't connect the dots there. They don't see maybe this was that driving factor behind the whole lot, not just the prolactin, but
Mhm.
reducing thyroid, reducing progesterone. The service is the only word I can come back to this. It's shocking. And then as for women, all I can say is I'm sorry. I'm sorry it is like this. And it is a case where we are going to have to pay out of pocket. And yes, sometimes that is going to be expensive. But if you want help and you want to feel better, it's the only way. And I feel awful, so I'm apologizing for something I didn't do. But it is what it, even with thyroid therapy, we're having to pay out of pocket, and it's a choice. Do you want to continue to feel like rubbish or do you want to feel better?
Right, right. It's another big problem. Doctors, I know doctors who've lost their licenses in Canada for prescribing whole thyroid. David Derry comes to mind. He wrote a book called Iodine and Breast Cancer. With iodine and whole thyroid, he was able to reverse breast cancers. Of course, we can't have that. He was in British Columbia. He lost his license. Um, this is criminal.
Yeah, it is. And again, a whole different conversation.
Yes.
So many rabbit holes to go down. But Carol, I know you have a busy day. This was a great start to my Monday, so thank you very much.
Oh, thank you,
Where
Karen.
can people find out more about you?
Okay, the wellnessbydesignproject.com is my website, and I have a YouTube channel by the same name. And when you air this, I'll put it on there too. So uh, I think between the two places, you can get a lot of background, and some of it may apply to you. And that's once you're armed with the information, it's a big step forward. And it also is so important that women and men too, you have to learn to be not only be in your body, but be the observer. And you
Mhm.
have to learn, that's the only thing you can do, to observe what's happening to you and look for the solutions. Use those solutions that you intuitively feel drawn to. Don't dismiss your intuition or drop those things that you don't feel good. Your body's trying to tell you something. And I think this is a great step forward for how we can get to a better place in our whole healthcare system as we learn to take care of ourselves. And we're number one. You talked about spending all this money. That's where you should prioritize your money, because if you don't have your health, you have nothing.
Oh, you don't. Your quality of life goes down the drain.
Yeah.
So you also offer meet and greets and consultations because I know a lot of people are going to want to talk to you. Actually, I'll book one. But this has been a pleasure. Maybe we will arrange to have you back on in the future if your schedule allows. But thank you so much. I know people are going to find this so valuable. And as you say, and I say, and even Dr. Platt says, it's all about helping people be armed with the knowledge they need to help themselves. You don't have to trust every word your doctor is saying. Like you just said, if your body is giving you symptoms or feeling a certain way, telling you it's not happy, then it's not happy, and you need to listen to that and take action.
Right.
Well, thank you so much for your time today, Carol. It's been a pleasure. I hope you have a wonderful Monday. Stay
Oh,
well.
yeah. And carry on. You're doing great work.
Thank you.